So we're back for another edition of 5 Questions with my favorite radiation oncologist, Dr. Chun at MD Anderson. Steve,
Thanks.
introduce yourself.
Well, I'm Steve Chun. Thanks, Ryan, for having me. I'm a radiation oncologist here at MD Anderson in our satellite network known as the Houston area locations. One area of interest of mine is small cell lung cancer.
So today we're going to ask 5 questions about small cell lung cancer. You ready?
Go ahead.
So first question, small cell lung cancer in a patient. How would you treat that, Steve? What would you do?
So I know some of what I'm going to say is perhaps going to sound sacrilegious to the traditional radiobiologists here, but it's informed by some of our historic outcomes of conventionally fractionated chemoradiation for small cell. I think the best information we have on chemoradiation for early stage small cell T1, T2 limited stage comes from the CONVERT trial. This was the large randomized trial done in Europe comparing 45 gray twice daily with 66 gray delivered at 2 gray daily with concurrent platinum and etoposide. What was neat about that study is, in addition to the primary analysis that was published, they also published a secondary analysis looking specifically at the outcomes of T1 and T2 limited stage small cell. Now, historically, we've always thought of these tumors as being radiosensitive, and I actually don't think that's true. I think they are what we call radioresponsive. I think if you treat them with chemotherapy and radiation, they will respond. But I think what's blatantly apparent, whether you look at CONVERT or any of the limited stage small cell trials, you have really pretty suboptimal local control with chemoradiation alone, even for a T1 to T2 N0 small cell treated on the CONVERT trial with chemoradiation. Long-term local control is probably only in the 60% range. That's somewhat surprising for what is purportedly a radiosensitive tumor. I actually think that small cell is pretty radioresistant, meaning that you can give high doses of chemoradiation, you may have a response, but it's gonna come back. It's not radiosensitive like a lymphoma. And I think ultimately, these radioresistant small cells, while they might respond in a petri dish and they might have certain alpha beta characteristics, one really has to get over that shoulder in order to control these. So um I have the bias that for these tumors they should be treated with hypofractionated radiotherapy if possible, if it's safe to do. A peripheral small cell, even something central, with a modestly hypofractionated approach, 50 and 5 or something like that, followed by consolidative chemotherapy, because we know that these have a high likelihood of metastatic dissemination. There's been a number of retrospective analyses on this. I think Dr. Charles Simone has been involved with doing some retrospective analyses on hypofractionated ablative therapy for these early tumors, but um, ultimately, even early stage small cells, I think, are pretty radioresistant, as suggested by the CONVERT trial. And and if I can give a higher dose, even though there isn't a ton of data on it, I would rather do something that controls the tumor than something that I know, chemoradiation is only going to have probably a 50-60% local control rate at best.
Is there a role for surgery?
So that's an interesting question. You know, 20, 30 years ago, there was that big analysis basically demonstrating that surgery for small cell in general had no benefit. But I think much in the same way, I see the surgical paradigms being challenged with locally advanced non-small cell lung cancer. I see them being challenged with small cell as well. I don't think it would necessarily be wrong if there was a T1 to T2 limited stage small cell that was removed surgically, followed by consolidative chemotherapy or even perhaps neoadjuvant chemotherapy to test disease biology before doing surgery. Um, I think what we should keep in mind is those surgical trials, or analyses, let's say, those surgical analyses for small cell lung cancer. I don't even recall that they were trials. Those were all done when small cell lung cancer presented in almost uniformly the locally advanced or very advanced stages, where I think we can all agree that doing some kind of a commando surgery is not going to help the patient. Um, these days, with low dose CT screening, we increasingly see these small T1 to T tumors that could conceivably be removed by surgery. And as I mentioned earlier, I'm not clear that conventional chemoradiation local control is all that great, even for early stage small cell. So I would support either an ablative approach or surgical approach if the patient is medically appropriate.
And by ablative, you mean doing SBRT to some extent, right?
Oh, that's correct.
Okay. Here's another favorite question because I see it all over the place. What's your feeling about what cycle with chemotherapy to start radiotherapy for a limited stage small cell patient?
So by the book, I would recommend starting by at a minimum of cycle 2. I would not go beyond cycle 2 because of the meta-analysis that showed bringing in local therapy is associated with a survival benefit. I mean, in years past, before they even defined a role of local therapy for small cell, they just let these patients go on chemo until they, progress and then do radiation or something like that. I actually think this goes back to what I was talking about earlier about small cell lung cancer being we've always, again, this is sacrilege to the traditional radiobiologists or basic scientists who say that small cell neuroendocrines are radiation sensitive and chemotherapy sensitive. Um, Again, I stress they are not sensitive. They are responsive. They will respond to chemotherapy, but they are not sensitive to chemotherapy like a lymphoma, for example. And you go beyond 2 cycles of chemotherapy, these things become resistant. They start progressing. They become harder to kill probably with radiation because there's a lot of genetic instability in these tumors, and I think they are able to readily learn and adapt to chemotherapy probably is a similar mechanism of action as radiation. And so you're selecting these, you're basically creating a radio resistant population just by continuing chemotherapy. And that's probably the best I can rationalize why not, why just keep going on with chemo. The other thing is we know if you just continue chemotherapy for whether it be an extensive stage small cell or a limited stage, 95%. And yeah, I mean, I would argue probably all of them, but we know at least, 95% are going to progress on chemotherapy. And so this is all background to, my recommendation that radiation start by cycle 1 or 2 at the latest. The most recent uh, cooperative group trial on small cell lung cancer, NRG LU005, mandated starting on the 2nd cycle. That was mostly to allow randomization and delivery of the study drug for that trial. I have started patients on cycle 1 when they don't have severe symptoms, but for somebody who has bad dyspnea, you need to get started quickly. You don't have time to come up with a good IMRT plan. Starting with cycle 2, I think is certainly acceptable. I think also the potential advantage of cycle 2 is you could treat the post-induction extent of disease, improve the DVH or the dose volume histogram, particularly the lung parameters for these big bulky tumors. But I don't recommend going beyond that for the reasons I've discussed.
Okay, that's really good. I kind of try and get the cycle 2 for whatever reason tends to be a sweet spot for starting radiation, you know?
Yeah, I've certainly treated a number of patients with cycle 2. I think it tends to be a sweet spot clinically because, these patients, maybe they end up in the ER or as an inpatient, and, you don't want to wait for a week to do IMRT, contouring, then planning, then QA. And you also don't want to just slap on a 3D field that's going to expose huge amounts of the heart and lungs to unnecessary doses of radiation. So, waiting until that second cycle gives you the time to, plan things in a rational way. It's kind of like surgery. A lot of people listening, maybe they don't know that I'm one of few radiation oncologists who was a surgical intern. And surgeries always go better when they are planned, when they are prepared, when they are thought out. They just do not go as well if you are under the gun, you're doing an emergency laparotomy at 2 in the morning because somebody got, shot or something. Um, the same is true of radiation. Rushing and trying to slap together a 3D plan for the first cycle of radiation is probably not in their interests. Again, if the patient's stable and you want to do that, and that's great. But cycle 2 gives us a little breathing room so that we can be deliberate, come up with a good plan. We're not, we don't have, we're not under the gun.
Good thoughts. Now, this is one of my favorite questions. Okay. Because when I was a resident, I was tormented by what was the cord dose when we gave 45 grade BID. Based on the old Teresa study where they never mentioned what the cord dose was in the paper. So it was always kind of funny as we had to learn other ways to figure out what they did in the trial back in the day when we were both much younger. But, what is your feeling or what dose do you use? Do you think BID is better or QD is better? I mean, once a day, twice a day, what's best outcomes for the patient?
So I really prefer the 45 gray twice daily regimen, although I recognize that a lot of my patients that I see at my institution tend to have the socioeconomic means to do that. We now have two large trials that have shown both Jeff Bogart's Alliance, or formerly CalGB trial. Actually, it was an intergroup trial. It was RTOG Alliance comparing 70 gray delivered at 2 gray daily with 45 gray delivered twice daily in 30 fractions. We have that trial, but we also have Convert that I mentioned earlier, which was done in Europe, 45 gray twice daily compared to 66 gray daily. Both of those trials were actually designed with the intent and the power, the statistical power, to show that the once daily regimen would have superior outcomes because it was dose escalated. Whereas you mentioned the Teresi trial, that was 45 gray twice daily versus 45 gray daily. That those were not felt to be equivalent doses. So it has always been in question whether the twice daily regimen from Teresi really provided that benefit. And so they believe that the daily regimens would actually be beneficial compared to 45 twice daily. Both of those trials did not see evidence of superiority for once daily dosing. And in fact, even, while it wasn't statistically significant, it's interesting that the 45 gray group tended to have a numerical, it seemed to be numerically a little better than the once daily treatment, although we can't make too much of that. I tend to prefer 45 gray twice daily because as a lower prescription dose, it's just, less dose, less cumulative dose to the body, to the lungs. I can get better V20s. I can get better heart metrics. But it is hard logistically. And it's also, it's 3 weeks of treatment versus, 6, 7 weeks of treatment if you're going by the CalGB regimen. In terms of core dose, the Teresi trial was 36 gray, although the most recent RTOG trials have listed it as 41 gray. I mean, I think basically with modern intensity modulated radiotherapy or even 3D conformal radiotherapy, there's no reason that the cord should even be that high. I really still aim for 36 gray. I mean, I think if you have a massive tumor that's creeping somehow around the vertebral body posteriorly or like a superior sulcus, maybe that might be pertinent. But I've never even, I can't recall an instance where I wasn't able to make 36, but I think that the highest I'd go is 41. It's published. Do I know what would happen if we expose the cord to prescription dose 45 BID with chemotherapy? I'm not really sure. I mean, I get the sense it's risky. I wouldn't do it. And so, I really, my upper limit of safety, I'd have a hard time defending with a medical board if I went above 41 grays, just because that's a published constraint. And so I wouldn't take the cord any higher than that.
Okay, good thoughts, Steve. I appreciate that. Just so you realize, I got a thing saying only 10 minutes left. Two more questions, okay? All right. Next question I have for you is this one. I'm seeing some information that we may have some breaking news coming out of ASCO that will really impact how we treat small cell lung cancer. Is there anything you can say or about this?
I am really excited to hear that there might be news coming out about the Adriatic trial, which was a trial looking at the concurrent chemoradiation backbone for limited stage small cell lung cancer. And patients were randomized either to receive PD-L1 directed immunotherapy with durvalumab or not. This is really important because even with aggressive chemoradiation for limited stage small cell, I think at best, our 2-year survival outcomes are really, only in the 50% range. This trial builds upon what we've already learned in extensive stage small cell, where they tried this first. And this is kind of mirroring what happened in non-small cell. They tried PD-L1 immunotherapy first in metastatic disease, and then they integrated it into stage 3 or locally advanced disease. And we know that PD-L1 directed immunotherapy, be it atezolizumab and IMpower 133 or the Caspian trial with durvalumab, both of those clinical trials showed a modest but significant survival benefit. And so this trial looked to add on PD-L1 directed immunotherapy in the consolidative setting. So after chemoradiation for limited stage small cell, very similar to the Pacific trial for non-small cell lung cancer. And it's interesting, the press release that was sent out by AstraZeneca suggesting a possible survival benefit. This is really important because we really haven't been able to move the needle forward for limited stage small cell. We've tried things like cytotoxic chemotherapies. We've tried different doses and fractionations. We've really been working the last 30 years since Teresi to move the needle forward. Although, probably the reason we haven't moved it forward is that our strategies haven't been based upon a really great understanding of biology. And so if this trial is positive, which I hope it is, we'll see, perhaps they'll talk about it at ASCO, American Society of Clinical Oncology, next week. It would obviously be a very important trial. I look forward to reading the results and hope that this is something new we can offer our patients to give them a hope for a better shot at long-term survival.
Yeah, I'm really excited for this ASCO meeting too. Last question for you. What's your thoughts on PCI?
So that is another great and controversial question. Historically, we have done prophylactic cranial irradiation. The dose has been 25 gray delivered in 10 fractions. And this is all of the historic trials were done prior to MRIs, which could tell us, whether there are brain metastases there or not. And so presumably a number of those patients that have been treated on the historic prophylactic cranial irradiation trial may have already had brain metastases, and that's where they derive the benefit. Obviously, substantial numbers of patients are being treated with prophylactic cranial irradiation who today do not have brain metastases and may never develop brain metastases. When you look kind of broadly across the data, the biggest benefit of prophylactic cranial irradiation is for limited stage disease, less of a benefit for extensive stage disease. The question now is, in the era of MRI surveillance and in the era of PD-L1 directed immunotherapy, is prophylactic cranial irradiation still needed? I don't have strong opinions on that. I I prefer to put these patients on the Southwest Oncology Group Maverick trial, which is comparing the two strategies. Half of patients were assigned to close MRI surveillance, similar to the Japanese study, and the other half of patients are assigned to prophylactic cranial irradiation that can be delivered either with traditional 3D conformal technique or with hippocampal avoidance. I've enrolled a number of patients on that protocol in the last few months. Um, you know, there, there's certainly arguments that could go either way for that trial. On one hand, you know, perhaps prophylactic cranial irradiation does reduce metastases and brain deaths. I think even in the immunotherapy era, our best indication of what's going to happen with brain metastases comes from the AstraZeneca Caspian trial. They published their long-term data and brain metastasis outcomes. Even with durvalumab, the rate of brain metastases with long-term follow-up for extensive stage small cell goes up to at least 60 or 70%. Whether or not prophylactic cranial irradiation is going to meaningfully change survival outcomes is a different story, though. So, perhaps there's a role based upon that data. On the other hand, okay, let's say somebody progresses early and you're monitoring them closely with an MRI and you salvage it then. So really, I think the question today is not, prophylactic cranial irradiation or nothing. That's how previous trials have been. The question is prophylactic cranial irradiation or close MRI surveillance. I think, prophylactic cranial irradiation or not, even with PCI, about 25% of patients develop brain metastases. I had one develop brain metastases in spite of prophylactic cranial irradiation recently who was enrolled on the SWOG Maverick trial. But I would encourage people to enroll patients on SWOG Maverick. That's really going to be the only way we answer this question.
Yeah, I currently look at it similar to the that study by at MD Anderson with Eric and them and where it was like SRS versus plus or minus whole brain, I think it was, and the SRS alone arm got close MRI surveillance afterwards. So I look at it similar to that. Hey,
Yeah, and I think what we should remember is that, when you look at Slotman's study that validated the role of prophylactic cranial irradiation, that was certainly not close MRI surveillance. That was, okay, you get PCR or the other arm, we just wait until you have symptomatic brain metastases. And if you're waiting for someone to develop symptomatic brain metastases before doing anything, I mean, okay, those patients truly are at risk for neurologic death. They're at risk for seizures. They're at risk for
yeah.
brain edema, and
And they usually present on a Friday.
on a Friday or on New Year's Eve, or this goes back to early in the conversation. It's always better to treat someone in a non-emergent setting than in an emergent setting, whether it's surgery or whether it's radiation.
Hey, I appreciate your time. I got to run back to clinic. We'll do this again in some other disease site in the near future. You up for that?
Oh, you bet. Well, pleasure is mine. Thank you for having me.
All right. Thanks, Steve.
You bet.